Thanks very much for the invitation to speak. And it's really my role to tell you how Barwon Health receives the mortality report that's been sent for the hospitals. And So just to let you know that Barwon Health, I'll tell you something about how Barwon Health reviews mortalities, the relevance of VASM to Barwon Health, and I'll discuss something about perioperative mortality rates, mortality from emergency laparotomy and fractured neck of femur en passant. And so in Barwon Health, every hospital death is reviewed by a mortality review committee by one peer, and they focus particularly on deaths that could have been prevented. Every surgical craft group holds a 6-monthly audit meeting, which it reviews all its surgical deaths and before the peers. And in addition, we have VASM, where we don't actually know what the feedback is to individual surgeons because it's under qualified privilege. And I can tell you, wearing a Barwon Health hat, that's extremely frustrating. And any particular cases that are get into the incident reporting system, we're already managing them and reporting back on them within 4 to 6 weeks usually. And we have a structure which looks rather horrible here, but we have a surgical critical care safety and quality committee that reports to the program and to the hospital committee and to the board committee, and we receive information from safety and quality reports, from VASM reports, and from the mortality review committee and the surgical craft group. So that all feeds in to trying to identify the issues and the areas for improvement so that we can set strategy. And we have been inspired, Stephen, by your report and by all your collaborators, and we welcome the Safer Care Victoria's focus on making safety and quality a health service priority and incentivizing services to put safety and quality top of the agenda, to go for continuous quality improvement as opposed to just quality assurance, and to report on metrics and to encourage clinical engagement. But I would still say at an individual hospital, the people who work in my hospital are not yet necessarily convinced that if it's going to cost money, the improvement is going to be made rapidly. So there is still a tremendous organizational focus, both on safety and quality reporting on the one hand, and also driven by an annual cycle of the bottom line. And that really hampers everybody in making those improvements. Ewan showed you that the perioperative mortality rates in Victoria are actually have plateaued, and they have plateaued, or they've maybe bottomed out at 0.3-ish%. And Claudia did show you this picture of the decline in perioperative mortality rates, both nationally, and it's absolutely true, this graph is the same for Victoria as it is for nationally, that we did see a great reduction in perioperative mortality rates, really from the year 2000 and then before the audits of surgical mortality. But I would say that every surgeon in this room would say that the reflective process of fulfilling in case reports and thinking about your cases, often many months later, even though we would like to do it more quickly, makes you think about how you can improve care. And so we've found it a very good process. And also to say that both nationally and in Victoria, those patients who die are the elderly, emergency patients, and we tend to make good decisions on elective patients and not operate on them if they're extremely elderly or comorbid, unless it's really necessary. And you can see where the graphs rise in the elderly and in the emergencies. And that's where we can really make a difference with emergency laparotomy and fractured neck of femur cases, which really have the highest emergency mortalities. So we received our hospital report, and I took the 4-year report and the annual report to a hospital meeting and to the Surgical Safety and Quality Program, and I presented some of the slides that I show you here. I showed the demographics. Barwon Health has less patients who die who are transferred, but pretty well the same emergency caseload of 84%, and 53% of our deaths were males. I show the specialty mix by years, and just to say here that it's important to see that it is general surgery and orthopedics that actually account for 2/3 of the mortality, and that there were deficiencies of care identified in 86 cases. In case you think we're improving too much, going from left to right across the years, there are 2 years in the first column. But nonetheless, there are less deficiencies of care identified in the recent years, though that's no cause for complacency. And this also I present to our hospital. This is our surgeon case completion rate, which is actually 89%. And I don't know how 10% of our surgeons are getting their CPD certificates or actually registering as surgeons with the medical board. But I expect that given that this is data that goes to the middle of 2017, there will be a much higher rate in the future. Otherwise, we've actually got a problem with people not filling the case reports in and still registering to practice. We had a slightly lower second-line assessment rate at Barwon Health compared with the state, but pretty similar to nationally. So I don't think we're any better, and I think there's a lot of statistical variation that's quite normal in some of these figures. And we share the information on age, gender, and urgency, and you can see that Barwon Health, like all other health services, actually sees its mortalities in the emergency patients and in the elderly. And we don't have very many deaths in patients who are classified as ASA 1 and 2. That was only 2.8%. And we don't seem to classify as many patients as elsewhere as ASA 5. So either we're better at not taking these people to theatre, or we're not as good at classifying ASA 5. But I don't think we're killing too many people that we shouldn't. There's something usually to be learned from every single death. The preoperative assessment, which is done by the surgeon, actually shows a very similar pattern to the anaesthetist ASA grading. And therefore, I'm reassured that most surgeons who are doing this retrospectively, with the anaesthetist putting the ASA in at the time of the operation, we're probably making a reasonable assessment of how likely it is that the patient dies. This is from the overall report, and I think that you've already been shown some of these figures, and that it's comorbid patients who are also most likely to die. And when we pick out what are the common diagnoses in Barwon Health for the surgical deaths, we see that it really is in that 2/3 of general surgery and in orthopedics. It is fractured neck of femur and it's emergency laparotomy that are the common causes. I noticed from Claudia's presentation, I think there were 1,200 emergency laparotomy deaths in the period that you were reviewing. And you can see here all the various causes. And one of the problems is emergency laparotomy. Some of the colorectal cases will also really be emergency laparotomy as well. So it's a question of having a hospital system to try and pick up all of those. And again, we didn't think that our common causes of surgical death were any different from VASMs. I did say I would say something about emergency laparotomy. This just shows you from what we called VILA, the Victorian Emergency Laparotomy Audit, and there is now going to be an ANZ Emergency Laparotomy Audit, which is going to be prospective like the UK NELA. But we've seen a decline in emergency laparotomy rates, and I put the Victorian rates and I put the Geelong rates that are not really statistically different. At the beginning of the period, we looked a little bit worse, and at the end of the period, we looked a little bit better, and that might be because of statistical variation. But it's most probably because we've actually been taking an academic interest over this in the last 3 or 4 years, and therefore we're discussing these things actively. But what the National Emergency Laparotomy Audit has shown is what makes it different prospectively is if surgeons estimate the risk of death with the anaesthetist before they put the patient on the table. Also, early recognition of sepsis, so that you actually decide whether the patient is septic and start antibiotic therapy within an hour of identifying sepsis, no matter whether or not the patient will be going to theatre many hours later. Those are two of the things that have made a huge difference. This assessing how high risk this patient is, and we also know from frailty scoring that patients who are frail, where their clinicians recognize that they are frail and actually have a discussion about how best to manage them and determine their goals of management, those patients also do better. And so there's a whole number of things that if we want to improve and set a strategic direction with emergency laparotomy, our big ticket mortality, where in the UK it was 10 to 15%, and in Victoria overall it's now 8.8%, but it was much higher. But I reckon we can take off another 2 to 3% of that if we actually start to actively do these things. And so we are in discussion with Safer Care Victoria about that, as well as with the anaesthetic and the RAC, ANZCA and RACSA also joining in NZELA. Just to show you a funnel plot, you've seen lots of funnel plots. We are hospital number 2, right in the middle of that line, and we've actually been very gratified by the fact that we report on 2 things with regards to fractured neck of femur. What proportion of people we get to theatre within 48 hours of arriving in the ED, and that is over 95%, and what proportion of people actually die, which is 2 or 3% in our hospital. When Dr. Foster was around, it was very much easier to look at that for all the 14 major health services. Now, unfortunately, until a Health Roundtable report comes out, which this is, it's very hard to actually know what's going on in the rest of the state and compare yourself with your peers. In terms of how VASM reports outcome, and VASM doesn't have denominators, it only has the patients who die. I do share what concern, consideration, and adverse event means with the hospital, and emphasize the common causes that VASM identifies of concern or that are adverse events, particularly, for example, delay. And if I just show these particular figures that come from our hospital report that show that we're probably doing all right in terms of delay in diagnosis, delay in transfer to the hospital. We are a much lower user of HDU and ICU than other places, but as our mortality isn't different from other places, and either we need more ICU beds or we're actually doing something right, or I don't know what that is. We're actually having discussions with ICU about that. We still fail sometimes with DVT prophylaxis, but haven't failed so much recently. And we tend to be good at getting consultants. Consultants go to every emergency laparotomy, and we have consultant supervision usually in the theatre, but not always. And post-operative complications, you can see we're similar to nationally and to the state. Unplanned return to theatre. I'd just like to say unplanned return to theatre should not be seen as a bad thing. In fact, the way we reduced our mortality after elective colorectal surgery was to increase our unplanned return to theatre rate. And so it's really important that this doesn't become a perverse indicator that actually makes people die because the surgeon doesn't want to see their unplanned return to theatre. We monitor this. We go through every case in Barwon Health, and our rate, we've set ourselves a target of 1%, and probably for 10 to 11 months of the year, we stay round about 5, 6, or 7, 0.5, 0.6, or 0.7, but every now and then we blip over. unplanned ICU admission, we are probably pretty similar, and readmission after surgery, again with the fluid balance issues and with deaths after significant infections. So I take the hospital through all this, but I believe that these graphs really talk about quality assurance. And within every case, yeah, you might have 30% of deaths with a significant infection, but I actually believe some of these deaths we can still do better on. And it's really important, if you're seeing graphs and charts with thresholds, that just because you're below the threshold doesn't mean to say there's nothing to learn. So in conclusion, I would actually say that Barwon Health has a similar to the rest of the state and nationally. We're trying to focus more on high mortality procedures, and I would like to be seeing that done much wider afield. We do use ICU less than other hospitals, and about 10% of our case record forms have not been returned. And if I knew who those surgeons were, Claudia, you would get closer to 100%. And qualified privilege won't allow me to know that, and I find that frustrating. In addition to VASM, we do our own reviews, and I think anyone that just relies on VASM and doesn't have a hospital process for reviewing every surgical mortality, you're really missing tremendous opportunities for improvement, because some of these are multidisciplinary. And our local audit and peer review provide the most incentives for improvement, and that I've found personally, and I can't speak for my colleagues, that the opinions of second-line assessors and first-line assessors have usually been very fair and have confirmed how I've tried to manage the case. And for myself, I would probably say I've usually been harder on myself in the reflection process than the first and second-line assessors. You don't know whether you did it for me, but for those of you who did, thank you.